welcome to the continuation of our Orbis Cybersight clinical case discussion series. In the past, we've covered strabismus cases in the last two webinars, and today we'll be moving on to some non-strabismus cases. I thought it would be nice to discuss in particular. For this one, we'll be covering cataract and glaucoma. And again, the point's not going to be to get through a large volume of cases. I've selected a few cases that I think highlight some common but difficult clinical situations. And as we go through this, I'll present the case, which will be relatively limited. We'll have some poll questions and discussion of those cases. And then I selected some corresponding videos that we can use for the teaching points. And I think I have about 4, maybe 5 cases for us today. You're welcome to submit questions during the webinar, of course. And as we go through things, I will periodically stop and answer those questions. I'll also be demonstrating a few features of Orbis Cybersight, particularly the general question, the search features, and the clinical discussion forums. So we'll go ahead and start on our first case now. I will switch to sharing my screen view with you. Okay. And so for our first case, this is from a friend of mine, Dr. Farakov in Cambodia. And this is a 20-month-old male who has been noted to have a large cornea since birth on the left side here. And there you can see his first photograph. So he had a diagnosis of congenital glaucoma, obviously, and underwent trabeculotomy twice. Even with those 2 trabeculotomies, he still had difficulty with his intraocular pressure, and you can see that his pressure was 28 millimeters of mercury, and he had this very large cornea of 15 millimeters. And I'll open up this case so we can see it in a little more detail. 15 millimeters, obviously, that's a very large cornea. Normal newborn being about 11. No. Oh, reshare? Yep. Okay. And move back. Well, actually, I'll just, okay, so am I not on share now? Gotcha. All right. Just need to move this out of the way. Okay. Okay, I'm going to stay in the PowerPoint here. And you've got the screen now, I assume. You can see it. Right, it's in PowerPoint. Okay, but we've got the PowerPoint on. Is that right? Yep. Okay. So 15 millimeters, obviously, it's a very large cornea. Normal newborn, again, being 11 millimeters, and normal adult about 12. As you get to this large, you certainly start to get to difficulties with opacification of the cornea. This one stayed relatively clear, but you can see that there is some kind of a ground glass appearance to it. All right, which brings us to our first poll question. In particular, what glaucoma surgery would you perform for this child? You have a few choices here, and maybe you don't even perform pediatric glaucoma surgery. But if you do, would you perform a goniotomy or a trabeculotomy? Or would you prefer a trabeculectomy with or without antimetabolites? Or would you do a tube shunt, or would you prefer to do something else? And of course, for this particular poll question, I don't think there's really a right or wrong answer. A lot of this is going to depend on our situations individually. Okay, and we'll show the results of the first poll question. And it looks like most people would do trabeculotomy, with a smaller percentage who would go on to a tube shunt or perhaps don't perform surgery. And I think that, yeah, I think trabeculotomy, especially if this was a very primary surgery, would probably be my choice with this one. But this case demonstrates one of the difficulties here in that you can see that he's had 2 trabeculotomies, but yet still maybe those were difficult, and Schlimm's canal was difficult to find, and that was described in the case discussion that followed. But so let's talk about how do we decide trabeculotomy over goniotomy. Is our next poll question here. What are the advantages of a trabeculotomy over a goniotomy? Is it the potential to open the entire trabecular meshwork? Is it that it does not require a clear cornea, that it can be performed on a wider variety of patients, or is it all of the above? And I think, again, this might be a little bit of a trick question with something that we'll talk about in just a little bit here, but let's see what our results are for right now. And all of the above, that's right. And that's actually a very good answer, because what you find is that we'll discuss how you can open the entire angle with trabeculotomy. Of course, one trabeculotomy might only open about 1/3 of the angle, but there are techniques that we'll discuss where you can open the entire thing. And it does not require a clear cornea, and I think that's one of the key elements. If you're only going to be good at one technique for congenital glaucoma, then trabeculotomy makes a lot of sense. And that's why it is applicable to a wide variety of patients. Now, on the converse, let's go on to our final poll question before we move on to the video elements of this. What are the advantages of a goniotomy over a trabeculotomy? I mean, there are some. Higher success rate has been sometimes mentioned, less risk of cataract, leaves the conjunctiva intact. Is it all of the above, or is it just 2 of those, the higher success rate and leaves the conjunctiva intact? So I think I use both these techniques, and I think I used to use goniotomy more because I felt it was easier to do. But I think as time has gone on, I've switched more to trabeculotomies. But there are some new techniques of internal goniotomies, which I think are interesting, or suture goniotomies that we can look at. All right, and most of you said A and C, which is higher success rate and leaves the conjunctiva intact. And I know why everyone is saying that. I think that is a bit of a misnomer with higher success rate, and let me tell you why that is. I think these are actually either equally effective, or perhaps even trabeculotomy might be more effective. And this is because goniotomies and reported success rates for goniotomies are only being done on patients basically with clear corneas for the most part. So to me, that means they have more mild glaucoma, whereas trabeculotomies are being done on the more difficult patients, people that have cloudy corneas and present late. And so the success rate may appear to be lower, but in fact, they're just more difficult cases. So I think that these are probably actually relatively equivalent if you could control the patient population that was getting those. All right, well, let's get on to some fun stuff. So the hard part about trabeculotomy is finding Schlimm's canal. So I wanted to go through this kind of step by step, and this is a kind of a stop motion video that we'll go through describing the steps. Now I'll go ahead and start the slideshow here. I do these with partial thickness scleral flap like you would for a trabeculectomy. Some people will just cut down at the limbus. One of my partners does that, and it's quite successful. But I like the fact that by lifting that flap, you can see this. I'm going to pause for a second. You can see this kind of blue to white transition. That blue to white transition is what we're looking for, because Schlimm's canal will either be there or just slightly behind it. And I don't see any in this particular photograph, but a lot of times you'll see little veins, vessels leaking kind of a watery aqueous fluid it'll be bloody aqueous, and those are good markers for Schlemm's canal. So here I've done this partial thickness scleral flap. I can see the blue to white transition, and now I've switched to a smaller blade. You can use something like an eye knife or a 75 blade or a very small spoon blade, which is what I use. And I start to make about a 2 millimeter radial incision over that blue to white transition, and I'm looking right around in this area. And I just go down layer by layer by layer, and keeping this area dry until I start to see a little bit of egress of aqueous. Now you can be too far forward and end up in the anterior chamber, and so you have to be a little bit cautious about how long you make this. If you get too far back, then you get over the ciliary body, and you'll just you'll be prone to being in the choroid rather than Schlemm's canal. So let me restart things here. So these little incisions, and again, here's kind of where I'm looking. This, you'll start to see, you can almost see the reflection of Schlemm's canal as we do this. You don't want to go so far deep that you lose your anterior chamber, but right there I think is a nice view of what I would consider prime candidate for Schlemm's canal. Now it's not always distinct. Some of these eyes can be really stretched out and therefore hard to tell where Schlemm's canal is. But once you get that, that appearance, I like to precannulate this with a piece of 6-0 Proline. So here you see we've cut one and either cut it blunt or blunt it with a cautery and then thread that in. And why do we do that? Well, it should thread in easy. If it doesn't thread in easy, then you're not in the right place. You're probably too far posterior. If it threads in super easy, and you can, what I like to do is once I thread these in, I like to strum them or flip them with the instrument. And if you're in the anterior chamber, you'll see the Proline end up here in front of the iris. So I just thread these in a little bit, maybe about 2 to 3 clock hours at the most. So they help confirm that you're actually in Schlemm's canal. The other advantage of doing this before you put the trabeculotome in is that it's kind of a marker for your trabeculotomy. Sometimes after you do the first trabeculotome, the chamber collapses and it's hard to tell. I'm going to pause again here. Back. Go to the middle here. Sometimes after you do the first trabeculotome, the chamber will collapse and it's hard to get into the second side. When you do insert the trabeculotome, you're putting in the bottom one only. The top one is just a reference so that you can find where the bottom one is. And I like to slide it in all the way. Sometimes if you slide it in all the way though, that puts the trabeculotome all the way over here and there's just too much tissue or it's not curved enough. So a lot of times if it won't rotate in easily parallel to the iris plane, you have to just back it out a little bit and then rotate it in. So you're probably getting 1.5 to 2 clock hours in each direction. And when you rotate that, I kind of stop about where this one's rotated, or maybe a little bit more. What I don't do is keep that trabeculotome going out over here. I don't want to get over the pupil. But also I don't want to completely tear out this middle part of the meshwork yet, because that'll cause the anterior chamber to shallow and we still have another half to do here. So I rotate it partially and then I withdraw it. And now I'm going to go back to the left side, or rather the right side here, and do the same thing with the trabeculotome there. Again, inserting 2/3 of it is usually where I can rotate it. And if the chamber has collapsed, I'll put in a little saline or viscoelastic to just kind of hold it open a little bit. You don't want to fill the eye with viscoelastic, obviously, because then you'll get potentially a pressure spike, but you need a little bit there. If you're too anterior, you'll get kind of hung up in the cornea and it'll look like you can see the trabeculotome moving against it. And again, here I've stopped just short of going all the way out. The chamber usually does shallow quite a bit and you'll get a little bit of blood reflux as you come out. That doesn't bother me. I'll usually not close the radial incision. I'll just close the flap as you see here. And I do use an absorbable. I just use a 10-0 Vicryl, but you can use a nylon too. And if the chamber is shallow, it'll usually reform just overnight. I don't get, as long as the iris is not touching, I don't get too concerned about that. So those are kind of the basic steps of doing a trabeculotomy the traditional way, but there are other ways to do this. The Prolene suture, so you can thread that around and do these 360 trabeculotomies, or there are the catheter systems, and we'll talk about both of these. The Prolene suture, I mean, this technique is not new. It goes back 30 years now to some of the initial descriptions. And there's a really interesting article from about 20 years ago or so from Dr. Beck and Lynch, where they were able to thread these Prolene sutures around Schlemm's canal 360 degrees. Or if they couldn't get it to go around 360 degrees, they would go as far as they could and then do a cut down and tear out the meshwork with this Prolene suture. And they had about an 87% success rate with lowering the pressure. Now that doesn't mean they had an 87% success rate of getting the Prolene to go all the way around. And really no significant complications there. One key thing that they did here, which I think is important to keep in mind, is they did intraoperative gonioscopy and monitored where that Prolene suture was going, because you can't really see it. And here's something that highlights what can happen. This happened to me, and I did two things wrong. One, I didn't monitor with gonioscopy while I did it, and also I was attempting this early in my career on someone who had had angle surgery before, so that I think there was some obstructions. But what you see in these photographs is that the one on the photograph on the left side of the screen is before the procedure. It's taken during the EUA, preceding the procedure. And then a few months after the attempted 360-degree trabeculotomy, I went back to do a new EUA and measure what the pressures were. And I found this scar. And this scar is where the Prolene suture had left Schlemm's canal and gone into the subchoroidal space and just kind of scraped the retinal pigment epithelium from underside of the retina as it went. And you unfortunately couldn't be more accurate with where this went. It went right down to the fovea, and it actually tracked through underneath the fovea. Now, I followed this girl for like 17 years now, and I can tell you, or 16 years now, I can tell you that her vision is quite good. She's 20/50 in this eye, and that's actually, I think, more amblyopia than it is this foveal defect, because this eye was cloudy for a long time. So I don't think it caused any damage, but it potentially really could. And I've also seen cases where the Prolene has appeared in the vitreous space and is coiled up in the vitreous behind the lens. So I kind of stopped doing these for a while. And here's a explanation. We say, well, you were feeding that suture in, and why didn't you know it was not going in the right place? Well, it's simple mathematics here. The circumference of a circle is 2 times pi and the radius of the cornea. And so it looks like I did that math wrong, actually. So the 2 and then pi, and then if you have a 13 millimeter corneal diameter, then that's going to be 6.5 millimeters of a radius. So rather than 81 millimeters here, you can see it's about 40 millimeters in length. So 40 millimeters in length, you can see you can easily get to the back of the eye if the eye has an axial length of 24 or 25 millimeters in this glaucoma eyes. You can easily get back to the fovea long before you would expect to see that suture exiting 360 degrees from Schlemm's canal. So it happens quite easy. And then several years ago, at least a decade now, the iTrack microcatheters came out, and I like these because they are illuminated. The small catheter is about the size of a Prolene suture. It has a little stabilizing wire inside it, has a fiber optic, and it has an already blunted end. And then a lumen if you want to do visco dilation. Of course, these were developed for adult glaucoma cases where they perform canaloplasties. But I think they're perfectly suited to doing 360 degrees trabeculotomies. We'll go back to this blunted end. If you do use a Prolene suture, to do 360-degree trabeculotomy. I recommend that you don't take a hot cautery, but take a cautery and let it start to cool down, and then just touch the end of the proline suture to it so that it's blunted or rounded. If you just cut a proline suture with scissors, it frequently has a very sharp point, and I think that that can help it to exit Schwemm's count inadvertently. So just try and blunt those down, but that's an advantage of the iCath or iTrack. And here's an example of an iTrack microcatheter that I'm using. And here you can see, so the approach is just like a trabeculotomy, but instead of putting in a trabeculotome, or we insert either our proline suture or this catheter system. Now, proline suture, if you're doing that, of course, you want to do gonioscopy and try and see the proline suture and know where it's going. So you have to stop and check it. However, with this iCath, iTrack catheter system and that blinking light, you just dim the microscope lights like we have here, and you could easily tell where this thing is going. And if it starts to go radial out to a subchoroidal space, you know it right away, and you can stop what you're doing. If that happens, I just back up, and sometimes I'll try to viscodilate. Other times I'll just go the other direction. It also, if you can't get it to go around, you can at least see where the blinking light is and know where you need to make a cut down to do a partial 360, partial trabeculotomy. I'm using a Sinskey hook here to retrieve it. I think I've found that to be the easiest way to do this, rather than putting your forceps down inside the small incision. And now it's laying on the sclera right there. I'm just going to grab it outside the incision. And I want you to direct your attention over here. You'll start to, as I pull this catheter there, you start to see the catheters coming across the pupil and the iris there. You get a bit of a reflection off it, and it's right up here right now. So this side of the angle has already pulled through. And as I pull on the ends a little bit more, you can see the rest of the catheter coming out. And just make sure you don't get hung up on the iris right here. Just go slow, and it usually will flop out. If it doesn't, you can just let go of the one end of the catheter and it will slide out. So that has some real nice advantages. Here you've just opened up 360 degrees of the angle in a single procedure. And I think that's a really slick way to do it. So preferable to do that with an illuminated microcatheter, but you could also do that with a proline suture if you are careful. And again, try to monitor it with gonioscopy. Also, don't do that as a secondary procedure. Do that only on unoperated eyes that have not had angle surgery before. All right. So we'll come back to another glaucoma case, but first, I'm kind of excited to go through a cataract case with you because I have a nice new video to share with you. And this is nothing special about this cataract or this case. This is a 4-month-old, and this 4-month-old is in China. And the question is, the patient is 4 months old, and they have poor fixation and following behavior. The mother and grandmother also had cataract. Now, in this initial history, we don't know the ages of that. But I would like to show you this one. So we're going to go, I'm going to open this up, do a new share here. Yeah, get the desktop open. All right. Yeah, you got that? Good. Okay. So now we're in the Cybersight Consult page, and we're actually looking at the case as it exists live online. And I'd just like to point out, so the way I found these cases was by searching. This is not one of my cases. This is from a friend of mine, Dr. Alex Levin. But if you want to find cases, use our search function up here. And you can put in anything you want. I mean, you could say, I want hyphema. And then you'll get all the cases of hyphema, and you can use these various search filters to customize which ones you see. All right, so just be aware that that search function is there if you have something of interest that you'd like to look at, and I encourage you to play with that. But I'm going to go back to our case here. So this 4-month-old, and so at 4 months old, we would have liked to have taken these cataracts out, of course, by 2 months of age to help prevent amblyopia and irreversible nystagmus, but we can still get some reasonable vision from these kids. So it's still worth doing the surgery even if you don't get them within that tight window. So poor fixation, of course, cataract in both eyes. Unable to visualize the posterior segment, so B-scan ultrasounds were done. And so there's a preview of that image. And I have a larger one that I'll show you in a minute, but let's open this up. All right, so here we're looking at the ultrasound, and the left is here on the left side of the screen, the right is on the right side of the screen, and we can see some findings there. All right, so let's go back to the PowerPoint here. Oh. All right, so this brings us to our next poll question. Let me go previous, let's go back here. Okay, so here's a highlight of the B-scan, just in case you couldn't see it very well. So this physician has diagnosed a nuclear cataract and is recommending phacoemulsification surgery for both eyes. All right, but so as we talk about this kid, this is an infant, 4 months old, and they have bilateral cataracts, and they have a family history of cataracts. As we look at this case, we decide how we're going to approach this. What are what's probably the most important factor from what we've been presented so far? Is it A, the age of the child, or is it the corneal diameter, which I don't know that we saw that anywhere yet, family history, or is it laterality? Which of these, when you're trying to decide whether or not to put a lens implant, what's probably going to be the most important thing? All of these more or less have a little bit of impact, but what do you think is the most important? So let's look at what our survey shows us, our results here. Age of the child and corneal diameter seem to be the two leading responses here, and then laterality, right? Family history, of course, doesn't make any difference. Now, family resource is good. Can they afford contact lenses or glasses? But I would say that corneal diameter, definitely. We don't know the size of these corneas, but I would say that if you have an eye that's 10 millimeters or less than 10 millimeters in corneal diameter, you really can't easily fit an intraocular lens into those eyes. And so to me, for me, that would be the deal killer if the cornea was just too small. Now, if you have a more normal sized cornea, it's 10 and a half, 11 or more millimeters, then you kind of can take all these other things into consideration. I'm certainly less likely to implant IOLs in very young children, although I still do. And I'm certainly less likely to implant infant IOLs, and so we're talking about kids less than a year of age, if it's both eyes. But each of our situations will be different. Where you are, it may make sense to do bilateral infant IOLs because you may never have access to these kids again, or that family may not be able to afford contact lenses or glasses, and so you have to do the best you can. We do know that from the infant aphakia study that at least for unilateral cases, there's a higher reoperation rate or complication rate with intraocular lenses in infants, but that doesn't mean you can't do them. All right. So then our next poll question, in this particular patient, what was the most concerning history or exam element that could have the most negative effect on visual prognosis? Is it the fact that these are bilateral? Is that a negative impact? Is it the family history of cataract in the mother and grandmother? Is it the B-scan or the age of the patient or the fact that they're already poor fixation and following and probably have nystagmus as well? What do you think is most troublesome here in this particular case. All right, and we'll go to our results. And I think appropriately so, a lot of you have said the poor fixation and following behavior, because obviously this is a little bit of a delayed surgery, so they already have nystagmus and they already have some irreversible amblyopia. However, I think for me, it's probably the B scan. And I'll show you what could be of concern here. Go back to our B scan. I find that this is a little bit interesting right here. So here's the optic nerve shadow, and then this almost looks like there is a stalk coming off of the optic nerve. Now that could suggest PHPV, persistent fetal vasculature, or persistent hyperplastic primary vitreous, which generally those eyes are smaller and they don't do as well because they frequently have other anomalies with them. However, this is a bilateral cataract and you have this family history, so I think it's probably less likely to be a PHPV, which is usually unilateral and non-hereditary. But I think that's something that you need to be prepared to deal with, that you could have a stalk or traction on the ciliary processes. So to me, that was the most concerning thing. All right, so let's continue on the other direction. All right, and so our final poll question related to this case, if we're going to perform surgery in an infant or young children in general, let's just make this a little more broad spectrum. Anyone under the age of 18, if you're going to perform cataract surgery, we frequently like to do primary posterior capsulotomies because it tends to opacify and needs to be opened. So, and if you have an opaque posterior capsule, of course, that's just as bad as having a cataract. So up to what age do you think one should perform a primary posterior capsulotomy? What is your preference? Is it just 1 year? Or do you do them up to 3 years? Or would you recommend doing up to 5 years or up to 10 years? All right. And I think that, again, this is probably something that's not exactly a clear-cut answer because there are always extenuating circumstances, but let's see what everyone says to say. 5 years, and then some at 10 and some at 3. And I think that for me, 5 years is what I use, but that's because I know that I usually have good access to my patients for follow-up, and that in a child with normal developmental status, they can usually sit at a YAG laser by the time they're 5 or 6, but not always. And so for that reason, some people might go higher. Some recommend routinely doing primary posterior capsulotomies in everyone up to 8 years of age. And so I can see that. I think 3 would be on the light side because that capsule could be opaque within 1 year, and now you have a 4-year-old that you either have to take back to surgery and do a vitrector capsulotomy, but there aren't many 4-year-olds that can sit at a YAG laser. 10 years, certainly most 8, 9, 10-year-olds can sit at a YAG laser. I think the only reason that some people might go higher on primary posterior capsulotomy age is because that you might lose access to the patient. They may not come back, or if they have developmental issues where you don't think they could sit at the laser. All right, so we'll move on here. All right, so this, I've on my cataract webinars before, I've shown you my technique, and my technique historically has been to put in an anterior chamber maintainer and use a vitrector. I do a primary posterior capsulotomy with a vitrector, aspirate the lens with a vitrector, and then inject the IOL in the posterior capsule. And then I go pars plana with a vitrector and open the posterior capsule. And that's what works for me, and I think a lot of surgeons in the US do that technique. However, this video that I'm going to show you now from Dr. Shakankirian in Egypt is really a nice example of how you can do all of this from the front. All right, and she has this nice bimanual technique. She's putting some viscoelastic in the eye now. And then here's her second instrument incision. Those are MVR blades. And then she goes ahead and does make a primary IOL implant incision. Now you could, I'll pause for a second, because you could conceivably not do the implant incision here. You could just later on open up one of your MVR blade incisions, because if you have these small injectable IOLs, the incision's small enough not to induce much cylinder, maybe half a diopter. However, if you don't have a small incision capsulorhexis forceps, or if you don't have a vitrector to do a vitrectorhexis, then going ahead and making your IOL implant and capsulotomy incision now is a good idea, but while you've got the eye firm. All right, so I'll back up a touch. So she's got her cystotome needle, initiates her capsulorhexis, and then she's got these nice small incision forceps. And I think it's easier to do it through the larger incision, like she's got a 2.5 or 3 millimeter incision here. But I think you could do this through one of the MVR incisions as well. And she's tearing a very nice capsulotomy. And that is certainly a pro move. I like this move coming up next. Here she's done some hydrodissection, but then she dials that nucleus out with the BSS cannula. And that's really great. I'm going to back up a touch here, because this is really a great illustration of. So she does a very nice capsulotomy, and I'll tell you that she does hundreds of pediatric cataracts a year, and she has very good hands, and so don't feel intimidated or inferior when you see this. I think she's quite exceptional in her abilities. But we can all tear these capsulotomies just a little more slowly and maybe less perfectly around. But I like the fact that she makes room in the middle by taking the saline cannula and doing kind of some hydrodelineation and dialing that nucleus like that. Because you need a little room and, all right, there you go. Advance back. Okay, so I came out of our video. All right, so I like this instrument that she uses, and I'll list these instruments on the website later on. But what I've got, struggle is real. All right, let me get to where these instruments come in, because these instruments are really great. All right, here we go. All right, so she's using a bimanual technique, and in her left hand, she has this small irrigation, small aspiration handpiece, and I think the opening in it is 23 gauge here. But this, you can see the end of it's rough. It's covered in like a diamond dust, and that allows her to strip off lens epithelial cells. And then this is the infusion over here. And you can easily switch left and right hands to reach cortex in different areas. So let's play this out. And because it's rough like that, it really picks up the lens cortex and strips it out. The lens cortex can be so sticky in children that this really removes it quite nicely. And if you were to get stuck there, you could just switch hands with these two instruments and reach that without having to put pressure on the capsulotomy. All right, so it's cleaned up quite nicely. Now, rather than going pars plana, she likes to do the vitrectomy from the front, and she likes to do it before the lens is implanted. And I know this is appealing to a lot of people who maybe don't want to go through the pars plana. So here she's made a small nick in the posterior capsule and is putting a little viscoelastic to lift the capsule off the anterior vitreous face, and now does a manual primary posterior capsulotomy. And you can see, of course, that the capsule is thin. It behaves a little differently, but the technique for tearing it is still essentially the same. And I'll pause this to point out a couple key things here. All right, so again, she's using those small grasping forceps. You could use Utradas or any other capsulotomy forceps. The anterior capsulotomy is perfectly nice round capsulotomy. She's made probably about 5 millimeters in diameter. And since she's going to be putting the lens in after this is open, she's keeping the posterior capsule opening smaller. That gives her a nice area here where she can put the lens implant in without catching the edge of this posterior capsule, because it is thin, and that's one of the downsides of potentially doing this technique, is that you can tear it and then have to fixate in the sulcus, potentially with optic capture posteriorly, but still your haptics might have to go in the sulcus. But here, she's keeping it small so that she can get her haptics in the bag, and I like that. She's going to use a vitrector next and remove the vitreous face here, which I think is preferable, because that vitreous face can serve as a scaffold for lens epithelial cells to opacify this. But if you don't have a vitrector, and some of us are in situations where we don't have a vitrector, you could, I think this would be better than doing nothing, at least tear the posterior capsule open and not disturb the vitreous face. Go ahead and put your IOL in, and that'll give you some chance of keeping a clear visual axis. But definitely it is preferable to do the vitrectomy like she's going to do now. She's doing it from the front, and those of us who are anterior segment surgeons mostly are more comfortable using a vitrector from the front. And you can see she's just, those lines, that's mostly the viscoelastic that she's in right now. But she's removing the vitreous face here so that there's not a scaffolding to support the migration of those lens epithelial cells. And once her vitrectomy is done, you don't have to do a lot of extensive vitrectomy. But once she's confident that she's got enough vitreous removed, now she's going to put in some more viscoelastic, and she'll separate out those capsular leaflets, because you want a nice separation so that lens gets injected or folded into the capsular leaflets without going through that posterior capsule opening. And you can see how that posterior capsule opening enlarges as you blow it back with viscoelastic. So you do have to be careful here. And she's using the type of lens that I like to use, kind of one of these monoblock Alcon lenses, which are injectable, and they come in different models. But I find these injectors to be pretty easy to use. And I like the fact that these open slowly. I think that's a real advantage when you have the posterior capsule open, or if you have an irregular anterior capsule. It allows you to get that in there atraumatically. And that delay in how this opens allows you to get your second instrument, like a Sinskey hook, in there and kind of dial these lenses into position without stressing the capsular edges. Even though that posterior capsule edge has been torn perfectly around, it is still a fragile item, and you have to treat it gently. All right, so there, she's got it in position. And while this is playing, I just have looked at our questions. There's a question about the extent of anterior vitrectomy in pediatric cases. Well, the extent of how much vitrectomy you might do is relatively limited. I mean, I think you can't really see the vitreous. I don't stain it in most cases. But you just want this central area here to be free of vitreous and go back a little bit. I might have the vitrector in there just doing small amounts of vitrectomy, gentle circular motions for a minute, okay, to give you some rough idea of how much vitreous is being removed. You just don't want vitreous sitting right here, and you don't want it coming forward. All right, so I think this is a beautiful illustration of how to do manual tears, anterior and posterior, and do a vitrectomy from the front and place an IOL. And I'll see that we get this video up live so that you can all benefit from this. Also, at this opportunity to announce that we have pediatric ophthalmology modules that will be live within the next month or two, and these will be interactive with videos and illustrations, and it'll go through some of our material that we've covered this past year. There's a module for step-by-step pediatric cataract surgery. There'll be one for glaucoma. There will also be one for basic and complex strabismus. One of the things, let me pop back up to our questions. We have a couple more, it looks like. So that was the extent of anterior vitrectomy. What should the surgeon do if the posterior capsule, I think there's, if it breaks during injection of the IOL, and also, is a 3-piece IOL better for eventual future explantation? All right, well, first of all, I don't think I ever plan to have a future explantation. I don't really anticipate switching the IOLs out, but either one of those will come out relatively easy if you do have to remove one, if you have a lens calculation that's way off. Both those 3-piece and the 1-piece will just dial right out without much fibrosis around them. So they're equal. If the posterior capsule breaks during implantation, you can't, if it's severe enough that you can't get that IOL in the bag, then you need to put that IOL, at least the haptics, in the sulcus. And that's one of the potential benefits of using a 3-piece IOL, which is why I'm doing these two questions together. That monoblock style IOL, like we just saw, those haptics are really thick, and you don't want those in the sulcus because they'll chafe the back of the iris and you'll get problems with inflammation and membranes. And so we don't put those in the sulcus. So if that were to tear your capsule while you were injecting it like that, I would pull it out. I would remove that IOL and I would switch to a 3-piece. And what I do is I put the haptics into the sulcus, and then I push the optic back through. I push the optic back through the anterior capsule opening so that the optic is sitting in the bag and the haptics are in the sulcus. If that would be my preferred position. Otherwise, you just have the whole thing sitting in the sulcus, and that's fine. All right. All right, so I think we've got all our questions answered right now, and we've got about another 12 minutes, so let me go on to another case here. All right. This is one that I've brought up because this question has come up several times. And you'll notice that this is not a patient case. This is a general question. What's a general question? General question is if you have a question about something that's not specific to a particular patient. So this physician has a question about cataract surgery and Marfan syndrome. And what is the best way to remove a dislocated lens in Marfan syndrome without a vitrector? All right, this particular situation, they don't have a phaco machine or a vitrector, and the patient's unable to go down to the hospital. And they've had some previous patients where the lens was totally dislocated in the anterior chamber, and because it was totally dislocated, that makes it easy to remove, right? And they did an iris claw lens, which are nice for these aphakic patients, and the patient did well. However, on another patient, they described that they had a superior dislocation of the lens, had difficulty removing the lens because it was still attached with some of the zonules, and the zonules wouldn't break. And this is a real problem because now you're dragging on the zonules, you're kind of dragging on the vitreous, and there is definitely a risk of retinal detachments. The rate of retinal detachment has gone down dramatically with removing subluxated lenses with a vitrector rather than lens loops or other extra cap methods. So we really, really prefer to do this with a vitrector. And I almost would say maybe you shouldn't do it any other way. And there are other ways to handle these patients if you don't have a vitrector. So they've had some good success in the past, but they've also had some problems. So I wanted to talk about this. Let's go on here. And I'll show you a way to handle this. First of all, let me show you my technique. This is not the most clear video, but it's good for our purposes, at least see what the technique is. Here, the subluxated lens is being stabbed with an MVR blade. And now the vitrector is being inserted into the lens capsule. I'll point out a few things here before we go on. So that initial incision was just a stab incision here about a quarter of the way across the lens. This allows us to put the vitrector in and aspirate inside the protection of the capsule without pulling on the vitreous, which will be lurking back here in the subluxation zone. This is why people get detachments from subluxated lens surgery, is that you're doing extra caps and you've got all this stuff open potentially, or you're lens looping this lens and you're pulling on the vitreous and pulling on the vitreous base. And kids, of course, have very dense vitreous, and so there can be a lot of traction, and there's a high chance of retinal detachment either in the immediate postoperative period or long-term because of these tears and breaks which are created in the retina. I'll also point out that we don't do these in the traditional position from the top of the bed. I usually do these temporal because we're trying to approach the lens with the vitrector approaching from the area of greatest luxation. So here the lens is luxated because I want to be able to reach the lens that's up here under the iris. So if I'm down here, I can reach up under there and get to all that more easily. So I position myself in that manner. Also, here I don't have an anterior chamber maintainer. I've simply used a 23 gauge butterfly needle. So if you don't have anterior chamber maintainers, you can just use a needle pushed through the cornea as your infusion line. Just make sure that that tip is staying off the endothelium, of course. All right, so let's play out this video. Because you just have a small opening, don't hydrodissect. If you throw in a bunch of fluid, it's just going to tear out that small opening. You're going to have a massive amount of fluid that's trapped. It doesn't get out of there. So it'll either tear out that opening. So getting started here is the hard part. There's no space at first. So you may have to turn the cutter on a little bit, but I'm using it with the port sideways, so it's not cutting into the capsule. Once you create a small cavity, now we're just using aspiration for the rest of the procedure. And what you're going to do is just strip the lens cortex into that small cavity and aspirate it, all the while staying inside the capsule of the lens. So it's an extracapsular technique, but we're inside the capsule of the lens. Rather than what I've done over time is I've switched more to an anterior chamber maintainer, or even you could use a bimanual technique, but there's not a lot of advantage in this case for that. What I do now, rather than cut the capsule with an NVR blade, is I just use the vitrector to cut more of a circular opening, and I'll make a small circular opening that's 2 millimeters or so in diameter. And that's a little bit of a stronger opening than that slit that was done with the NVR. So here we've probably got about half the lens out. And again, this is all done inside the capsule. And then once you get the last little bit of this lens out, as we aspirate this, then you're going to go back to the cutting. And as you go back to the cutting, you're going to cut all of the capsule out of there now so that there are no capsular remnants. As you go back to the cutting, I will say you have to be careful, especially when you're working over here, because this is going to be the hardest part along the iris edge to get that last little bit of capsule opening or capsule remnant. You don't want to get this port of the vitrector up against the iris and take a bite out of the iris, especially on a blue-eyed patient, because it'll be quite obvious externally from a cosmetic standpoint. It also can bleed. So don't be very careful and make sure you keep when you're using the cutting action of the vitrector, make sure you keep it back from the iris and use a very limited amount of vacuum as you do that. All right, so that's a really nice technique to safely remove the lens in cases of lens subluxation. But our physician that we're dealing with here, they don't even have a vitrector, so what could you do alternatively? Well, all right, so we talked about some of the surgical tips with positioning and capsule opening in the iris. What if you don't have a vitrector? Well, let's look at that a little bit. let's go to the whiteboard here for a minute. All right, so let's draw, not a very good eye there. All right, there we go. An eye, let's just say this is going to be I'm just going to make this be the iris. All right, so we've got a dilated, and we see that we have this subluxated lens. Now, when they're only mildly subluxated like this, right, these are the zonules, like the case we just saw. When they're only mildly subluxated like that with a dilated pupil, you have to do the best you can in terms of doing refraction through this part of the lens. And that, of course, there will be some cylinder there, and they're usually highly myopic. But if they're starting to get luxated to the point where you need to remove the lens, usually that lens is more highly luxated, right? It's halfway or more than halfway. Those are the ones that now they really don't have any good optical zone here. The lens is so far off that the refractions are crazy. I think that and so if this was an undilated pupil, right? So let's just make a smaller version here of an undilated pupil. I mean, that person's going to have something like this, undilated. And that's not really good. So what I do, if you didn't have a vitrector and I had to treat this patient, what I would do is keep them dilated all the time. I would keep them dilated like this all the time. And I would do an aphakic refraction through this part, and then fit them with aphakic spectacles. And that would be a way to make them functional, because over here there's so much astigmatism and myopia, it's just impractical. But if you stay over here in the aphakic part, the zonules are so few and far between that they don't interfere with the vision. But you can then have them wear aphakic glasses and be functional. And now eventually, maybe that lens is totally out of the way or comes loose. If it comes into the anterior chamber, you can lens loop it out. If it floats into the vitreous, it doesn't hurt anything as long as the lens capsule is intact. So that would be, if I didn't have a vitrector, that would probably be my approach to a patient like this. All right. And let me go back to our questions. All right. The question is, do you do a peripheral iridectomy in all pediatric cataracts routinely? So no, in terms of peripheral iridectomy, I think I almost never do a peripheral iridectomy in pediatric cataract cases. About the only time I have to do peripheral iridectomies are Peters. So Peters anomaly, where they have these central corneal opacities, I'll do optical iridectomies. If someone had pupillary block because they had a lot of fibrosis and adhesions to the lens, I would probably just go in and free up those adhesions, and I've not had to do peripheral iridotomies. If you're having problems with needing peripheral iridotomies, it's probably because you're having a lot of inflammation and that there's been a lot of lens material left behind. If you have the lens in a sulcus, that's a reason to do the optic capture. It puts that optic back a little bit further so that you don't need a peripheral iridotomy. And we've got another question I'll go to here. And the question is, do you use trypan blue to stain the posterior capsule before a posterior capsulotomy? I don't, and I don't know that there'd be any, it will stain. I don't know that there would be any huge benefit to it. You can usually, if you have a decent microscope, you can see those edges. I think my concern would be visibility, but I haven't tried it. If anyone else has tried it, please let us know if you found it to be useful. I personally haven't. One of the things we talked about, general question, and before we kind of wrap things up, well, let me show you a couple other things. That was a general question that was submitted that had to do with lensectomies and Marfan cases. And If you're submitting a general question, that's under the new request. Here, you'd find that would pop up there. So feel free to use those. So we're at the top of the hour and the end of our time. Please, if you have requests for other future webinars, let us know. I do have more cases that are specific to cataract and glaucoma, and we can finish those next time. We can also do some other non-cataract, non-glaucoma cases. We can do some oculoplastics and retinoblastoma cases, nasolacrimal cases, and things like that. So until next time, thank you for your help and attention, and have a good day.